The most interesting now setting for advanced disease, metastatic disease, is again the frontline treatment. We have been seeing the evidence in late lines, but now we'd like to give immunotherapy to start. Probably also because the immune system is stronger in the beginning of the disease than later on when the patient and the T cells are completely exhausted, right? There are many, many trials ongoing. I cannot even count them, 20, 30, 40. But what is interesting is to categorize them. I think we have been looking at what we have to look at in terms of monotherapy, just giving pembrolizumab and high PD-L1. I'm not sure we will reach really better data giving only immunotherapy checkpoint inhibitors. But then you have combination of checkpoints plus chemo, and you have the combination of checkpoint and checkpoint. So CTLA-4 and anti-PD-1 or anti-PD-L1. But there will be the new checkpoints, TIM3, GIT, LAG3, IDO. So probably in this multimodality immunotherapy combinations, we will see some new partners coming. They are being studied now in phase 1 in late lines, but the good ones will probably come also frontline. So the main question will be, will we be seduced or will the result look better by having chemo-immuno or by just sparing chemotherapy for later on and starting with immuno-immuno combinations? If I had to prefer a strategy, I would choose immunotherapy combination because I like the idea that our patients can spend 1 year, 2 years, 3 years, I don't know how much time without having chemo. Because we don't like chemo so much. It's toxic, it's difficult, and it's really not personalized. So this would be good, but we need to have some positive results to do that. So these data are awaited. Probably the most important one to come in the next months, there are 3 of them. One is MYSTIC. MYSTIC is CTLA-4 and anti-PD-L1 versus chemo. We know the PFS is negative, but we wait for the OS. So this would be good because it's CTLA-4 and anti-PD-L1 as potential standard frontline. The second is Keynote 189, which is the second arm of the Empower. It's chemo plus pembro versus chemo. It's interesting, but no bevacizumab, just chemo, pembro versus chemo. So it's interesting. It should read also early next year, I guess. And the last one is Checkmate 227. It's nivolumab, which is being combined in a very complex manner, subdivided to PD-1 positive or broken down by PD-1 positive or negative into various strategies. Nivolumab plus ipilimumab, so anti-PD-1 CTLA-4, or nivolumab plus chemo in the negative ones. And all this landscape will let us know what's probably the best treatment in this patient for the future. I'm sure it's going to be lots of debate. To me, I remember when I started lung tumor, it was in the early 2000s and at the end of the 90s. Nobody wanted to do this job because lung cancer was chemo versus chemo versus chemo. We made many trials to do a better chemo and it failed. And it was less than a year survival, right? Less than a year, 9 months at the time. Then came the molecular characterization. So we knew EGFR, ALK, there was some targeted therapy, but a small proportion of patients. But there was, so this became a bit more exciting, right? And suddenly comes the immunotherapy. When you can tell your patients that you have a new class of drug, which is well tolerated. You keep your hair and you can continue to go to work. Amazing, right? And we're just at the beginning, so we'll probably improve the strategy. But even at the beginning, some patients are still alive at 5 years. A small proportion, but between 15 and 20% of these patients are here at 5 years. The 5-year survival with chemo, it's not complex. It's not a difficult number. It's 0. It doesn't exist. So you really completely change the fact that when you see a patient, you have some unknowns. You don't know who is the patient who will respond. So you said to the patient, maybe it's going to be you. You have to know that some of the patients do not benefit, but some do. And if the patient responds or has a benefit, you don't know how long it's going to last. So I like the unknowns because it's also about having hopes for your patients and creating hope for the patients themselves, allowing them to have some hope in life. So I like it's a new paradigm. I mean, there are lots of things we don't know, but it's also a kind of a new opportunity to try to, we shouldn't say these kind of words, but try to have long-term benefit. My colleagues would say cure cancer. I think that's the vision of tomorrow, trying to cure cancer. And that's something we didn't discuss in lung cancer when I was starting this discipline.
One area of interest besides locally advanced non-small cell lung cancer is from patients with a limited number of metastases, the so-called oligometastases. So the oligometastasis paradigm deals with patients who have not very extensive disease, but a limited number of metastatic sites, between 3 or maximum of 5, in which we could think of potential cure for a small number of these patients. A previous meta-analysis suggested that if patients have no mediastinal nodal disease and a limited number of metastases, they do better. But the interest has really been erased by 2 trials which closed prematurely in the US, which suggested that in patients with limited number of metastases, there's a big difference in progression-free survival in one study between about 3.5 months to nearly 11 months by administering what they call local consolidation therapy, radiotherapy to the chest and stereotactic radiotherapy to the other side. So there are 2 randomized trials prematurely closed and 1 non-randomized trial reporting that this strategy is a feasible one to be exploited. If you add to that in selected patients, immunochemoradiotherapy may improve long-term survival, plus the fact that stereotactic radiotherapy may activate the immune system, you can appreciate why there's a lot of interest in designing these trials, comparing the best of immunochemoradiotherapy with immune-activating radiotherapy in a patient population with limited number of metastases. I think that's where we think that we could just make a big enough impact to show improvement in survival. So that is a fascinating area for research. Many investigator-initiated trials underway to see whether we could translate the gains in advanced disease and in locally advanced disease to oligometastatic disease. And that's where the so-called abscopal effect of radiation, focal radiation, enhancing the immune system in the whole body to also attack other sites which are not irradiated. I think we need to understand it a lot better, but the idea is very appealing for us.